Hello, my name is Dr Andy Franklyn-Miller and I'm one of the consultant sport and exercise medicine physicians at the Sports Surgery Clinic here in Dublin. Today I'm going to talk to you about Achilles tendinopathy. That's really pain around the back of the Achilles or back of the calf extending down into the heel. It's an incredibly common condition. We know that 10 or 15% of new recreational runners or walkers will experience pain in the Achilles, and up to 60% of elite marathon runners each year will have similar problems with the Achilles tendon, which is a main load generating structure. What we mean by that is what it does is lift your heel off the ground. So when you're walking up and down a hill along a flat surface or running, it has a massive part to play in helping with that propulsion. What we can do is start to have a little look here at the anatomy. And if we look at the back of the leg, we can see the calf extending down into the heel, and that structure here, which is the Achilles tendon. If I take it to the side for a second and then take the skin off, we can see here the calf muscles at the top extending down into the Achilles tendon, which attaches to the heel, and you can see it's like a suspensory pulley. There are also some tendons around the outside of the ankle. These are called the peroneal tendons. And again, on the inside, we can see the tibialis posterior tendon. And both of these groups of muscle and tendon help out the Achilles and can often, when this gets particularly sore, can give ongoing pain. The Achilles tendon itself, often it presents with pain in this middle portion down just above the heel with some swelling, a thickened part of the tendon, and pain on movement, particularly on getting out of bed in the morning, or whether or not you've gone for a walk or a run and come back from that run, sat down for a while, and then started to feel the pain again. So it's usually pain on movement or exercise, or after a period of rest following that exercise. It's progressive, doesn't tend to get better on its own. And if we talk a little bit now about the structure of the Achilles, were we to be able to cut it in half and look at it in cross section, we can see it looks a little bit like a jelly bean. And it's made of long vertical fibers of a substance called collagen. Think of a pack of dry spaghetti with those fibers, and you've got a pretty good reflection of what they look like. There are two types. There are type 2 and there are type 3 fibers. And we know with type 3, those fibers have a lower breaking strain and so tend to respond faster to overload. If the tendon's starting to overload, it starts to get thicker, a more oval shaped, fatter tendon. And then what we can see there with that is that there are still plenty of long vertical fibers of collagen, plenty enough to take load and not risk rupture of the tendon. But in between those fibers, we start to see some more cooked spaghetti, some wet, swollen fibers that may be broken or may just be fatter. On an MRI scan in cross-section, we can see that as little tiny dots, white dots on a black background in a fat-suppressed scan. And so we can see early evidence with an MRI scan. If that's left to progress, it doesn't really settle down with rest alone. What we can see is that oval tendon on the anatomy, underneath it sits a fat pad, and that allows the tendon to slide past the back of the ankle and give you more space to move. And overlying the tendon lies a cling film layer called fascia. And what we know is that as this progresses, the fat pad starts to stick to the back of the tendon with new little blood vessels and some pain fibers. And underneath the cling film fascia layer, there starts to build up a fluid collection. As time goes on, that can lead to the progression of these intrasubstance areas of degeneration to a larger area within the tendon, which dies off, and we have an intrasubstance tear, a sort of pocket of damaged fibers within the middle of the tendon. In some cases, that progresses on, and although this is rare, less than 1% of what we would see, whereby the full depth of the underside of the tendon here all loses its structure and becomes dead and not functioning. Now look, the good news here is that there are good treatments available along the way, and broadly speaking, those treatments allow us to jump back a step at a time. We're going to spend the bulk of this talk really focusing on getting back from this intrasubstance degeneration to a normal tendon with a heavy strength loading program, and Colin Griffin is going to talk you through that. I might just spend a little bit of time further up here Here, where the fat pad and the fascial fluid are collecting and it's painful and you're not able to do the strength and conditioning work, what we would commonly do is something called a high volume saline injection. And what that does is allow the tendon to be separated off from those areas of collection of fluid and adhesion. Very effective at getting you to be able to do the strength program back here, which is of course the mainstay of all tendon rehab. Here, where there's an intrasubstance tear in the tendon, the high volume saline doesn't really seem to do enough. And in our practice here in Dublin, we would take platelet-rich plasma injection, some of your blood, and inject it into that damage defect to see if we can accelerate or trigger a healing response. It doesn't negate the need to do the strength program at all. And very rarely, at the very worst end of the spectrum here, there may be a need for surgery to cut away that damaged part of the tendon. But as I say, the main focus here is on an effective strength program to reverse these changes. And I'll hand over now to Colin Griffin, who will talk you through that program.
So as Dr. Franklyn-Miller said, rest isn't the answer for Achilles tendinopathy. It needs progressive exercise. So the main aim of a rehabilitation program is to improve the tendon's ability to handle high stretch loads and to improve the strength of the calf muscles. And this is important particularly for people who ultimately want to get back playing sports like running, field sports, or even people who want to get back playing golf or walking long distances during the week as part of their regular physical activity. So the key here is to find a level of exercise that you can tolerate. And if you think of a scale from 0 to 10, with 10 being worst case scenario of pain and 0 being no pain, we want to be able to exercise below 4 out of 10 and wake up the next morning and not be any higher than a 5 out of 10. And it's important that we space out those high loading sessions, that we have enough time and space to allow the tendon and the muscles to recover and adapt. So for a lot of people who are quite sore, we may start with an isometric calf exercise. And it's a nice way to load the tendon and kickstart the process without making it too sore. So as you can see here, Jack is holding a heel raise position for a sustained period, about 30 seconds to start with, maybe 4 or 5 times, holding a weight that's manageable but slightly challenging. And the key here is to keep the weight through the big toe. And you want to feel the whole calf working here and be nice and still. And once the pain settles down and that exercise gets easier, we will start into a single leg calf raise. So we're going up and down. And the key here is just a little pause at the top, as you can see Jack doing, and a slow controlled descent back down again. And again, we find a weight that you can do that's slightly challenging but manageable. And again, the key here is to keep the weight through the big toe. And for people who are maybe not as sore, we may start into this and bypass the isometric exercise. And the key here is to try and keep progressing the weight each week, that we don't get stuck in the same thing for too long. And once you've built up a decent level of calf strength, we want to improve the tendon's ability to handle those high stretch, short and cycle loads. So we'll bring in exercises like hopping. So you can see Jack there doing a pogo hop. So it's a bouncy exercise. You want to be short on the ground and try and keep the knees straight so the ankles are doing most of the work as opposed to the muscles around the knees. We're trying to get maximum height for the shortest time on the ground. So these exercises can be done at home if you can get your hands on a dumbbell. But the key here is to find ways to progress them each week, either add extra weight or add extra reps. And to be patient, because some people this can take a few weeks to recover, and others it can take several months. And it doesn't mean to stop all activity. You just find a level of activity. So if you run, still run, but just watch your morning after response and to progress up slowly.